Hi, good afternoon. This is take two of us being live on Facebook. Sorry about the earlier edition. We had a little technical difficulties with our mic. Hopefully you can hear me louder and clearer now. So we're going to go ahead and restart from the beginning. Again, my name is Fuzz Fernandez. I'm one of the surgeons at Baptist Hospital that performs weight loss surgery, and we're going to be talking about weight loss surgery this afternoon. If you have any questions, please feel free to send them in, and we'll try to answer those questions as we go along. A little bit about myself is I've been a surgeon here at Baptist for about 14 years. I went to undergraduate at Georgetown University. I then went to medical school at Duke's University. For those of you who are Blue Devil fans, go Blue Devils tonight. And then finished up my training in surgery and weight loss surgery in Richmond, Virginia at MCV, or the Medical College of Virginia. And then I came to Baptist in 2003 and started the bariatric surgery program here. And I'd like to talk to you about our program, which we kind of feel is pretty special and innovative. We have two branches to the weight management center now. We have both a medical and a surgical avenues. We have doctors and nutritionists, exercise physiologists, and psychologists that work with both sides, and in order to offer patients the best treatments out there for obesity. Obesity is a disease. It is the leading cause of preventable death in the United States. Number 2 is alcohol, and number 3 is tobacco. So we definitely want to try to make some inroads to try to knock down obesity and help people with obesity have a better life. We are an accredited center by both the societies that govern our surgeries, the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery. And also we are accredited by a number of insurances, being a preferred provider for insurances like Blue Cross Blue Shield, Aetna, and United Health. One of the things that makes our center different than other surgical centers is that we offer a very wide array of expertise to help people with their journey. Surgery is not a quick fix, but it is a very powerful tool for people to help get control of obesity and maintain their control over obesity. But our other members of the team, the nutritionists, the psychologists, and the exercise physiologists, are important parts of that process to help people get the tools along with the surgical tool to be able to keep this problem in check. We do have monthly support group meetings as well as online support for our patients after surgery. We have 2 locations that we can offer patients for their follow-up. One's in Greensboro on North Elm Street, and that's where we're coming live to you today. The other one is in Winston-Salem on Country Club Road. Now, both locations are outside of the hospital, but the hospital that we perform all these surgeries is North Carolina Baptist Hospital in Winston-Salem. And hopefully our patients have very limited contact there, do most of their care and aftercare at our off-site locations, which are much easier to access. So let's talk a little bit about obesity and what makes a person a candidate for obesity or weight loss surgery. Of course, one of the main definitions is what's called the body mass index, or the BMI, and easiest way to do that is to find a BMI calculator on the net and plug your numbers in, your height and your weight, and it'll give you a number. So anybody whose BMI is above 40 is a candidate for weight loss surgery, or anybody who has a BMI between 35 and 40 is also a candidate for weight loss surgery, as long as they have other medical issues, things like diabetes, sleep apnea, or arthritis complicating their obesity. Now, there are a number of other requirements, like people have had to have tried some form of diet or exercise plan in the past, maybe even medications, as surgery is not considered a first-line treatment for obesity. But if people have tried those diets in the past and there's no other contraindications, things like suicidal ideation or active substance abuse, then people are candidates for weight loss surgery. Now, there are 4 types of surgery we offer at Baptist: the adjustable gastric band, the sleeve gastrectomy, the room-wide gastric bypass, and the Blvd pancreatic diversion duodenal switch. All these surgeries are performed laparoscopically, meaning through the small incisions, which helps reduce the amount of pain people experience after surgery and helps to have a shorter recovery after these surgeries. Patients generally will spend 1 to 2 nights after these surgeries in the hospital and then go home to continue the recovery there. Now, we'll talk about each of these different surgeries briefly. I'll start with the adjustable gastric band, with the disclaimer that we have not performed a band placement since 2013. The reason for that is that we haven't found as good weight loss with that procedure as with the other procedures, and actually have found that more patients struggle or have problems with that procedure long term. In a lot of studies from Europe and the United States, 50 to 60% of the bands that were placed are having to be removed because of problems with the band, either if the band slips, erodes into the stomach, or people start to experience obstructive symptoms, things like nausea, heartburn, vomiting, even if the band's deflated. So for that reason, the band is not really a mainstay of treatment anymore in our program. Though there are maybe certain special situations in which the band is an appropriate treatment for weight loss, and we can use it then. Now, as far as the other procedures, we'll start with the sleeve gastrectomy, which is the most common procedure we perform. It's also one of the newer weight loss procedures in our armamentarium. It was first described in the medical literature back in 2004, and slowly but surely since then has become the most popular procedure in the United States of America, along with our program. Probably 2/3 of all surgeries that are done. It's a very simple procedure, but it's a very permanent procedure because there's no reversing this procedure once it's done. Physically, what we do is we remove about 2/3 to 3/4 of the stomach when we perform that procedure. And we see very good weight loss results, very similar to the room-wide gastric bypass procedure, which is a more complex procedure. Patients generally will spend one night in the hospital and be able to go home on a liquid diet the day following the surgery and continue the recovery at home. Now, of course, it's important to kind of follow the guidelines that our nutritionists and exercise physiologists are going to set, including taking a multivitamin, calcium, B12, and iron, and progressing from your liquid diet up to a regular diet. Now, there is some risk at surgery, though this is one of the safer procedures we have. The biggest risks are going to be leak and bleeding, though those are fortunately very, very rare, and we haven't had, I personally haven't had a leak since 2011 with this procedure, and major bleeds requiring reoperation are extraordinarily rare. The more common thing we can see is an increase in reflux symptoms after the sleeve. 10 to 20% of patients that have a sleeve gastrectomy will have either worsening of their existing reflux symptoms or development of new reflux symptoms after this procedure. The majority of these patients we can manage with just medication alone and do very well. It's very rare, though, that we have patients that, despite taking those anti-reflux medications, which are things like omeprazole, Zantac, they still have symptoms break through that they need further treatments. There are some other surgical procedures we can do to help with reflux in those cases for those patients. Generally, patients with the sleeve will lose about 50 to 60 pounds of every 100 pounds they're over, i.e. an excess body weight loss of about 50 to 60%. And generally, people do fairly well maintaining that weight loss long term, though there is a chance of weight regain with the sleeve gastrectomy, like the other procedures. Generally, the risk with the sleeve is about 20 to 25%. As far as out of work with the sleeve, it's generally about 2 to 3 weeks, though patients that have a fairly sedentary job, not a real high physical strenuous job, can get back to work as early as a week after surgery. The next procedure we'll discuss is the room-wide gastric bypass. This is the oldest procedure in our armamentarium. This one's been around since the mid-60s. More complicated than the sleeve and definitely has more risk than the sleeve. But we do not remove any of the parts when we do this procedure, so this procedure is reversible. The way we perform the procedure is we create a small pouch out of the very top part of the stomach. We staple off the rest of the stomach, but we do not remove it. And then we reroute the small intestines in order to get a part of the small intestine up to the pouch so the pouch can empty, and then reconnects the small intestine back to itself. Very effective for weight loss. Patients will lose anywhere from 60 to 70% of their excess weight, or 60 to 70 pounds of their weight of every 100 pounds they're over with this procedure. And the weight loss maintenance is very similar to the sleeve, where people will maintain most of their weight loss off, but there is about a 20 to 25% chance of regain. One of the advantages of the bypass is that it's actually a very good reflux procedure. So for patients that have really difficult to control reflux, the bypass is probably the best choice. One of the downsides of the bypass is people can develop ulcers or stenosis at that top connection between the pouch and the small intestine. Things like smoking and anti-inflammatory drugs like ibuprofen, Aleve, Motrin, those are going to place patients at higher risk for developing those complications. So people with bad arthritis or bad back pain who need those medications to kind of get their day going and get through life are generally not going to want to have the bypass. But you can take those medications with the sleeve. Now, the bypass is really good at helping patients with things like diabetes to see improvement in their diabetes, both in the reduction of medications they're on and hopefully coming off all their medications. In fact, one recent study showed that the effectivity of the sleeve for diabetes is actually very close to the bypass. So both those procedures can help patients with that kind of problem. Now, there are risks to that surgery. It is more complicated. So things like leaks or bleeding can certainly occur with this surgery right after surgery, though fortunately they're very rare. The more common thing we see, particularly in that first month, is some nausea and dehydration. It is definitely a little more difficult to eat and hydrate after the bypass compared so with the sleeve. So on occasion, patients do have to sometimes come to the hospital or our clinic to receive IV fluids to help them kind of catch up and keep up after the surgery. Now, one thing I've not talked about so far is the vitamins, but the vitamin replacements that are going to be asked of you after both the sleeve and the bypass are the same. And they include a multivitamin, calcium, B12, and iron. And generally that is for life after these procedures. Now, if you take a multivitamin with iron, most patients are going to be able to maybe keep up with their iron levels and not need the iron long term after the sleeve and the bypass. But most patients, particularly menstruating females, are going to need an extra iron supplement to keep up with that. Next procedure we'll talk about is the biliary pancreatic diversion duodenal switch. This is the newest tool in our sack of tools here at Baptist. We just started performing this procedure last May, though this procedure has been around since the late 80s, 1988 to be specific. It is a more complex procedure than even the bypass, with more risk than the bypass. With this procedure, we sleeve the stomach like we do with the sleeve, so that part is not reversible, but then we bypass the majority of the small bowel. So as far as helping patients with diabetes, sleep apnea, hypertension, or even high cholesterol, this is going to be the most effective of all three procedures for that. 95% of diabetics will be off their medications and stay off their medications for the rest of their life after this procedure. But with that malabsorption, or that degree of malabsorption that we see with the switch, comes some costs. And I think that's some of the downsides to the switch, is that this is the procedure that requires the most vitamin and mineral replacement of all three of the surgeries we do. So it requires a double dose of the adult multivitamin, a much higher dose of calcium and iron, along with B12. And then, of course, because of the malabsorption, it requires people to take vitamin A, E, and D as well, the fat-soluble vitamins. The degree of malabsorption we see with this procedure is much more than we see with the bypass. For example, with the bypass, about 10% of the fat a person takes in is not absorbed. With the switch, it's more like 70%. So that degree of malabsorption is what helps this procedure be more effective against those medical issues we talked about, like diabetes, high cholesterol, and high blood pressure, but it also makes it the most effective for weight loss. Patients losing anywhere from 70 to 80 of every 100 pounds or over. Generally, those patients will keep that weight off. The chance of gaining the weight back is the least with this procedure, only about 5%. So when you look at weight loss curves for all three procedures, the procedure that's doing the best at 10 to 15 years is definitely the duodenal switch. Now, unfortunately, because of the malabsorption, there's about a 1 to 2% chance of protein-calorie malnutrition with this procedure, where patients may require either IV nutrition, a feeding tube, or even another surgery to help reduce the amount of malabsorption with this procedure. Recovery after the bypass and the switch are pretty similar. I think we still see more of the nausea, dehydration with the bypass than we do with the switch, but I think patients experience more fatigue and tiredness with the switch because of the rapid weight loss that we see with these procedures. And the weight loss is very rapid with all of these surgeries. Generally with the sleeve, the majority of the weight loss happens between that first 6 months. With the bypass, usually by month 9. With the switch, though, we see weight loss into that 12th and 18th month. All procedures generally will plateau by that 18 to 24 months after surgery. And then that's where the work I tell all my patients comes in, and that's where people really have to really adapt to that new lifestyle. And that's the key for success with all these surgeries, is changing the way you think about food, changing the way you eat food, and also changing what foods you pick afterwards. because it's an important combination of those three processes that's going to help kind of keep that weight loss off long term. Other issues that people talk about after these surgeries is the excess skin. What's going to happen to all that extra skin I have? And so, unfortunately, it varies from person to person. I can't give you a great answer. Depending on the amount of weight loss you have, more than 100 pounds or more, generally some of those patients will choose to have skin reduction surgery. Parts that people will operate on include the arms, the breasts, the abdomen, and the thighs. And we've had some patients have all those done. Generally, what I recommend to all of our weight loss surgery patients is make sure you keep up with your protein and vitamins. Exercise is an important part of helping to tone that skin and may help reduce the need for skin reduction surgery down the road. But generally what we recommend to people is waiting about 24 months after any of these surgeries or till the weight's stable before deciding to have one of these surgeries, because the skin is an organ and is important in the recovery, but the body tends to skimp on the skin nutrition after these surgeries, so it suffers the most. But it does recover some of its bounce back down the road, so it may change even after 18 to 24 months. So I'd like to thank you for coming today. If you have any more questions, we do have a seminar at both locations where you can attend in person or you can come watch our seminar online. And thank you for your attention.